Welcome, everyone, to another episode of Dr. Mercola's Cellular Wisdom, where we try to unlock the body's best-kept secrets without sounding too much like mad scientists. I'm Ethan Foster. Some call me the unblinking observer of all things strange and wonderful in healthcare.
And I'm Alara Skye, your friendly neighborhood quickwit who believes there's always room for a good laugh, even when discussing the modern labyrinth we call healthcare. We like to say this show is where curiosity meets comedy, and occasionally the absurd.
That's right. In our quest for clarity, we sometimes dig up more bizarre truths than we bargained for. Or, to put it another way, we're the folks who look under the rug that's under the rug. Today, we're talking about an unsung trio of letters that's got its fingerprints all over our health bills: PBMs, or pharmacy benefit managers.
PBMs are sort of like the big backstage crew at a theater, except imagine they're charging you extra for every light bulb and piece of scenery. Not the best analogy if you're a fan of backstage crews, but let's just say it gets complicated. These folks started as simple claims processors who were supposed to make our drug payments easier. But somewhere along the way, they evolved into what some might call drug world gatekeepers.
Indeed. If you've ever wondered why your medication costs are climbing faster than a cat chasing a laser pointer, PBMs might have something to do with it. So, let's unravel how they went from mild-mannered middlemen to the mighty barons of prescription pricing. From controlling which drugs your insurance covers to setting reimbursements for pharmacies, they've got a hand in every slice of the healthcare pie.
And they've become very good at slicing that pie. Some say PBMs like to slip in sneaky charges or pocket rebates, all the while telling you, don't worry, we're saving you money. It's a little like the friend who offers to handle the lunch tab, but then somehow you end up paying for the entire meal with a 20% tip, twice.
Precisely. It's not that we're saying PBMs are all wearing black hats, but they do operate in an environment that's as transparent as 10 layers of tinted glass. We're going to peel back that tint today and see what's behind it.
Let's start at the beginning, like the dinosaur era of health insurance. PBMs showed up to simplify paperwork. Insurance companies didn't want to handle the daily avalanche of prescription claims, so they outsourced that job. PBMs negotiated drug prices with manufacturers, settled up with pharmacies, and the rest of us assumed, well, great, one less chore for insurers.
Right. If that's where the story had stopped, we might be praising PBMs as unsung heroes, but success can be oh so tempting. Soon, PBMs expanded their scope. They began to merge with insurers, invest in drug companies, and basically create a giant web of financial connections that would make any spider proud.
It's a neat trick, isn't it? You start by saying, I'm just the middleman. Then you realize that, by controlling the middle, you can also control the beginning and the end. Somewhere between those ends are the rest of us, paying the bill.
You mentioned a key word: control. PBMs decide which drugs appear on those magical lists of what's covered by your insurance. That list is what pharmacists, doctors, and patients rely on when picking up their prescriptions. If a medication makes the cut, your insurance might pay for part of it. If not, well, get ready for sticker shock.
And guess who decides which meds make that prestigious list? PBMs. There are so many question marks about how those decisions get made. Sometimes drugs with very convenient rebate deals from manufacturers get top priority. Other times, more affordable options are mysteriously absent or stuck behind mountains of paperwork.
That's the rebate pumping phenomenon. PBMs say, hey, drug manufacturer, if you give us a nice, shiny rebate, we'll put your drug on our top tier. That means more patients get steered to that expensive drug, often when a cheaper, equally effective option is available. The kicker is that the PBM pockets a good chunk of that rebate. Meanwhile, the patient wonders why their copay is so high.
It's like a loyalty program, except the only people who get the sweet points are the PBMs. And the rest of us? We get to pay for it, sometimes without even knowing we're being nudged toward costlier medications.
Another practice folks might have heard about is spread pricing. That's where a PBM charges your insurer a certain price for a drug, but pays the pharmacy a smaller amount, pocketing the difference. The insurance company sees one number, the pharmacy sees another, and the PBM quietly rakes in the spread.
If that were a carnival game, you'd think it was rigged. But in this scenario, it's not your stuffed bear at stake. It's your health. Let's imagine you're paying $20 for a medication. The pharmacy might only get $15, while the PBM collects that $5 gap. Multiply that by hundreds of thousands of transactions, and that's quite a nest egg.
And from an outsider's perspective, it's hard to unravel. Insurers claim they're getting you a good deal. Pharmacies assume that's just how reimbursements work, and patients typically have no idea what the real cost is.
That lack of transparency is how PBMs thrive. Or, as some might say, just trust us. But for independent pharmacies, that trust can be disastrous. They often operate on razor-thin margins, like, if you sneeze, you could blow those margins away. When the PBM reimburses them too little or drags out payment, they can't keep up.
Indeed. Imagine you're a small-town pharmacist who knows your patients by name. If your main source of income is shortchanged or delayed, how do you pay your staff, keep the lights on, stock inventory? It's no wonder so many independent pharmacies close or sell out to major chains that have their own PBM connections.
Right. There's a chain reaction here. PBMs keep prices high and reimbursements low. Independents struggle. and the big corporations swoop in to buy them. Then those same big entities further consolidate their influence, meaning less competition. And less competition, of course, paves the way for less consumer choice, higher prices, and a continuing cycle.
Meanwhile, the actual pursuit of health sometimes feels like an afterthought. For instance, preventive care is seldom emphasized, especially if you look at how reimbursements are structured. If you keep people healthy, you don't generate as many prescription claims. That's bad for the business model of an industry that thrives on ongoing drug revenue.
It's a wild dynamic. We have the technology, the knowledge, and the resources to prevent so many chronic diseases. But the system, as is, can subtly discourage that. Why focus on root causes if you can keep dispensing medication after medication?
That's the question. This shift from short-term claims processors to de facto gatekeepers has had profound consequences, not just for our wallets, but for our quality of care. Imagine going to the doctor, expecting to get some thorough guidance on preventing a condition like diabetes, only to find out your insurance will only cover minimal checkups or certain superficial blood tests.
So you might miss early warning signs, develop a chronic condition, and then guess what? Now you're reliant on a string of prescriptions. That's a goldmine if you're a PBM, an insurer, or a major pharmaceutical company. You get a customer for life, just not necessarily a healthier one.
Let's also look at the big picture of who owns these PBMs. There's something called the Big Three in the world of mega investors: BlackRock, Vanguard, and State Street. They funnel money into so many different sectors: insurance, pharmaceuticals, medical devices, you name it. The result is a web of financial interests so interconnected, it makes your phone charger drawer look organized by comparison.
Yes, and when the same giant investment firms have stakes in drug manufacturers, PBMs, and insurers, it's like a closed circuit where everyone involved can profit from the same cycle. It's one reason the PBMs can continue with business as usual. They've got the backing of massive financial powerhouses.
The question is, what do we do about it? Some people say we need strong regulations to bring transparency to the system. That might mean ending safe harbor rebate rules, requiring PBMs to show their real costs, or even separating PBM services from insurance companies entirely.
I like that idea. Let's have a big scoreboard visible to everyone. Here's how much is charged. Here's how much is reimbursed. Here's where the rebates are going. And if we separate PBMs from insurers, that giant love fest where they can keep money in one pocket while extracting from another might be disrupted.
A more radical solution, encouraging cash pay models for routine and preventive care. Some people pay a monthly membership at a direct primary care clinic, bypassing insurance for basic services. That's not perfect for catastrophic issues, but for many daily health needs, it can be more transparent and less tangled in that PBM labyrinth.
And it fosters a more direct relationship between doctor and patient. You're not spending hours on hold waiting for pre-approvals or deciphering coverage tiers. It's like stepping out of a complicated dance and saying, "I'll just take a walk. Thank you."
The challenge is that this approach isn't widely available or might be too costly up front for some folks. Still, there's momentum for it in certain circles. People are realizing that relying on a system built on profit from chronic illness might not be the best route to wellness.
Another piece of the puzzle is the food and consumer products industries. Processed junk, loaded with chemicals, refined sugars, addictive additives. That's how many chronic diseases start. So big food corporations profit from selling you these products, and then big pharma and PBMs profit from selling you the drugs once you're ill. Quite the partnership.
Precisely. It's like if a restaurant served a meal guaranteed to give you heartburn, and then the same restaurant sold you the antacid. But if you ask, could you maybe just avoid the stuff that causes heartburn in the first place? They'd say, shh, that's not on the menu.
And we see the same synergy in how these industries market their products. We're told that the new miracle medication will help keep everything in check, so we never address the underlying diet or lifestyle that could have prevented the condition. A nasty cycle indeed.
To break that cycle, you have to wonder if we need a grassroots shift, people educating themselves, opting for more preventative measures, supporting local pharmacies or direct pay providers, and demanding better coverage from insurance plans. Political action is often slow, but consumer action can sometimes move the needle faster.
True. It's encouraging that more people are seeing beyond the pop-a-pill approach. You see folks turning to functional medicine, advanced nutritional counseling, or direct testing. If enough people do that, maybe we'll undermine this perverse incentive to keep patients on perpetual prescriptions.
The reality is that PBMs are not going anywhere overnight, though. We're talking about massive corporations with deep pockets, protected by complicated lobbying and media influence. Many in media rely on pharmaceutical advertising money, so it's not in their best interest to run constant exposés on how PBMs operate.
It's that classic line, "Don't bite the hand that feeds you." If the top sponsor of your show is a huge pharmaceutical or PBM-affiliated brand, you might find your editorial voice strangely subdued on the topic. It's like a polite dinner guest not mentioning the questionable odor coming from the kitchen.
So the checks and balances that we expect from a free press might be less robust when it comes to challenging the healthcare behemoths. That's why these issues often come to light only through independent journalists or smaller platforms.
Exactly. That's also how we ended up hearing from folks like Brigham Buhler, who spent years in healthcare and realized how entrenched these profit motives are. He points out that you can have a system set up to help people, but if it's more profitable to keep them ill, that's where the investment flows.
Which brings us to a bigger philosophical question. If the profit model rewards chronic disease management more than actual cures or prevention, how do we realign it?
One answer might be large-scale public demand for transparency and accountability. Get legislation that says, no more secret rebates, no more hidden spreads. The sunshine effect might reduce some of the worst abuses.
I'd hope so. We also might see court cases or state-level actions, like some states that discovered PBMs overcharging Medicaid. When officials realized they could save money by cutting PBMs out of the equation, it was like, wait, maybe we should do something about this.
Let's also not forget the potential for technology to help. If we had robust platforms that compare drug prices and show you exactly what the pharmacy gets versus what the insurer pays, it might be easier to choose or even bargain. Information is power, after all.
Until the PBMs decide to buy that platform too. But for now, maybe it can help keep them a little more honest.
You know, it's worth mentioning that some PBMs argue they genuinely save money for patients by negotiating bulk discounts. The question is, are they saving us as much money as they could, or are they quietly pocketing way more than they'd like us to know?
Even if they do provide some savings, the overall cost curve keeps rising. If you're paying less but the base price is inflated, you end up with an illusion of savings rather than an actual discount.
Imagine a friend telling you, I got you a great deal on a painting, only $800. You later discover the painter typically sells these for $400. Not exactly the bargain you were hoping for.
And that's the gist of how patients feel. Unless you read the fine print or consult about 20 different pricing sources, you never really know what you're paying for. Or, more accurately, who you're paying.
We've talked a lot about the cost issues, but there's also a human toll. Hospitals, especially rural ones, can't keep up with all these delayed reimbursements. They might have to reduce staff, limit services, or close entire wings. And the patients in those communities face longer commutes for care, which can be life-threatening in emergencies.
Right. It's not just a matter of paying an extra few bucks for your prescription. It's about access to care, whether your local hospital can afford to stay open, whether your pharmacist can continue offering personal service.
Meanwhile, the PBM executives might be living comfortably, to say the least. It's not a moral judgment. It's just an observation of how incentives align. You can't expect a company whose revenue depends on administering drug benefits to advocate for a world with fewer drug benefits.
Hence the push toward that indefinite line of prescriptions for chronic conditions. Once you're on them, it's easy to remain on them, and preventive steps, while beneficial in the long run, don't bring in that steady stream of revenue.
It doesn't have to be a conspiracy with shady meetings in back rooms. It's just a structural problem. The system is set up in a way that profits from long-term repeat customers. Prevention cuts into that. It's as simple as that.
Exactly. So if we're going to fix this, we need to change the structure, or at least create alternatives. Whether that's direct pay clinics, legislative overhauls, or supporting new models of pharmacy, something has to shift.
The good news is that we're not alone in recognizing these issues. Patients, some politicians, independent media figures, healthcare rebels, they're starting to raise their voices. And once enough people demand transparency, either the system changes or new systems crop up that better serve patients.
In the meantime, you might want to keep a critical eye on your drug pricing. Ask questions at the pharmacy. Compare your copay to a cash price. Sometimes you'll find paying cash is cheaper than using your insurance, which is a surreal realization.
Surreal, but not surprising, given what we've learned. Also, if you're able to invest in thorough preventative measures, you might avoid some of these cost traps altogether. That might be the best hack. Stay healthy enough to minimize your engagement with a tangled healthcare system.
Right? And let's just say that if everyone wanted to put PBMs out of business by being healthy, it might actually push these companies to pivot. Maybe they'd get into a new line of business, like organic farming or something beneficial.
A comedic fantasy. But who knows? Stranger things have happened. For now, we'll keep shining a light on these hidden corners of healthcare.
Definitely. This wraps up today's discussion on PBMs. If you've been curious why your prescriptions seem to cost more than your entire grocery bill, hopefully we've shed some light on that. There are real reasons behind it, and they're not always pretty.
But we're confident that knowledge is the first step toward change. So thanks for tuning in to Dr. Mercola's Cellular Wisdom, where we try to keep you informed, entertained, and hopefully a bit healthier.
Indeed, we appreciate you sharing your time with us on this deep dive. If you like hearing complicated matters made simpler and sometimes sillier, stick around for future episodes.
Absolutely. So until next time, I'm Alara Sky, encouraging you to question everything, especially if the label says, "We're here to save you money."
And I'm Ethan Foster, reminding you that sometimes the real prescription for better health is just knowing what's behind the curtain. Thanks for listening, and be well out there.
Take care, everyone. And remember, a little knowledge can go a long way toward keeping your wallet and your cells happy.
We'll see you next time on Dr. Mercola's Cellular Wisdom.